in fact, this whole evening is possible mainly because of Dr. Sidebottom, and it was he was the first person who agreed to be on this session. It was the inspiration that I took up from him. I have been taking advice and mentorship from Dr. Sidebottom periodically. What a wonderful educator, being himself, and a generous person. Dr. Sidebottom is a BDS, FDS, RCS, MBCH, FRCS, and several other degrees to his credit. Is a consultant oral and maxillofacial surgeon in Nottingham University Hospitals, UK. And since 2001, he's in full-time private practice. He has several accolades to his credit. He's a specialized interest in management of temporomandibular joints and facial deformities. The most important aspect, what I like about his CV, is that he's an expert in National Institute of Health and Care Excellence in UK, and that makes him an absolute authority on what is the right procedure and how it should be done, the do's and don'ts. He's the right person and authority on this. It's an extreme pleasure to invite Dr. Andrew Sidebottom. The stage is all yours. Thank you so much.
Thank you very much, and thank you for organising this, Taranjit. It's always a pleasure to speak on the same webinars as such experts such as Darpan and my good old friend Florencio, who I'm looking forward to catching up with in person in the next week or so. So what my role was originally to cover open surgery and alloplastic replacement. Now, clearly that's a massive topic, and what I've done is realistically look at open joint surgery, dealing mainly with internal arrangement, and very briefly covered what you can expect for alloplastic replacement, and leave the alloplastic stuff, which probably is a lecture in itself, to another day if needed. So what I'm going to cover in the next 20 minutes or so are the indications for open TMJ surgery, the alternatives and rationale behind it, the outcomes for this, and then a very brief coverage of alloplastic replacement outcomes. So what do you do when TMJ arthroscopy fails? And realistically, you need to treat what you've found. We've seen that TMJ arthroscopy is the gold standard as a diagnostic tool. We know from studies from Chi Yang and from Japan that MRI is really only accurate at diagnosing a disc tear in about 50%, and possibly at diagnosing degenerative changes in around 30 to 40%. And that's using advanced MRI with 3 Tesla machines. And the majority of the machines, certainly in the UK, and I would guess probably in India, will be 1.5 Tesla machines. And our radiologists aren't as experienced as the likes of radiologists working in Chi Yang's unit, where they're looking at hundreds of TMJ scans every week. So I think we've got to be sensible about this and say, yes, arthroscopy is the gold standard, as it is both better diagnostically, and it gives a therapeutic success rate of around 80%. So if you've done an arthroscopy of the upper joint space and you found that it's normal and the patient still has ongoing pain, then realistically you need to refer them for pain management, because you'll otherwise end up with a very full clinic of patients in pain, and you won't get a chance to see the patients that are actually going to come to surgery. On that note, we reviewed our outcomes between a 5-year period, 1-year outcomes of 596 arthroscopies. The majority of these, as is the case in internal arrangement, were female, and the average age of the group was 40.3. In that group, 65%, 390 arthroscopes, had a positive finding. Of those, 9% went on to open joint procedures and 2% went on to TMJ replacement. So you've got to be doing a lot of TMJ arthroscopy to then go on to need to do open joint surgery and alloplastic replacement, because around about 80 to 90% of patients that come into the clinic should be able to be managed conservatively without the need even for arthroscopy or arthrocentesis. The interesting point of this study was that despite having a disc tear located at arthroscopy, and Florencio has already quoted my paper, which says that arthroscopic diagnosis in my hands is near to 100% accurate at diagnosing a disc tear, only 39% of patients with a disc tear subsequently had to proceed to open joint surgery. That basically means that if you find a disc tear, you need to wait a short while and see whether the patient gets better, because some of them will adapt. However, finding a disc tear compared to other positive arthroscopies, there was a significantly greater need to carry on to need further surgical intervention. Similarly, if you have a disc tear, there's a far greater likelihood of needing to progress to a joint replacement compared to those patients with other arthroscopic findings. So positive arthroscopy outcomes do lead to worse outcomes, but a disc tear symptoms may settle in 50% of cases without need for further intervention. So I would suggest when you've done your arthroscopy, no matter what you find, you mobilize the patient, you manage their symptoms conservatively with the splint as well, and wait at least 3 months before deciding to proceed with any further intervention. Because we need to do no further harm to the patient. Based on Hippocratic School Epidemics Book 1, practice 2 things in your dealings with disease: either help or do not harm the patient. And that includes trying to have a go when you may not be the best person to do that. So don't be afraid to refer on to someone with more expertise in an area than you have. So as we've seen from what has been discussed earlier, the first stage surgery should be simple, level 1 arthroscopy, lysis and lavage. This relieves symptoms in around 80% of patients. It's superior diagnostically than MRI and will give that diagnostic ability over and above an arthrocentesis. It's diagnostic. 50% of patients with a disc tear will get better without need for further treatment. And we've seen from a number of studies that added medication such as steroids or hyaluronic acid give no benefit. This multi-center study by Gary Bullo's group in the US showed this, and it may in fact cause harm to the patient. So I always quote myself on this. I had a knee arthroscopy some years ago, and it wasn't quite settling down, so the surgeon decided to put some hyaluronic acid into my knee. Subsequently, at 24 hours, I had a grapefruit in my suprapatellar pouch of fluid, and it's continued to have crepitus in that joint ever since from ongoing synovitis. So some patients are allergic to these materials. And as Florencio showed also, the steroid can cause joint surface damage. So it's a double-edged sword. So moving on to opening the joint, which approach do we use? And there are a number of approaches, but by and large, what we would use for internal derangement is a modification of the preauricular approach. That can either be in a skin crease as marked, or you can run down behind the tragus and dissect a lot more skin. The risk with that is that you can cause damage to the cartilage of the tragus due to either direct damage or avascular loss of the cartilage. And so I tend to use just a standard preauricular incision as marked. If you want more access, you can extend that into the hairline. So the indications for open surgery: always failed conservative management, always put some local anesthetic into the joint to see whether this relieves the pain. Because if it doesn't, why would you expect opening the joint up and doing surgery on it is going to relieve the pain? I would always consider arthroscopy in the first instance and base my surgical treatment on the positive findings that I get with that, bearing in mind that you don't see the lower joint space very often unless there's a disc tear. And therefore, you could base your diagnosis on a positive CT or MRI finding of damage to the condyle or problems within the lower joint space. We've then got recurrent dislocation or hypermobility, and then surgical pathologies such as osteochondroma, synovial chondromatosis, and condylar hyperplasia. So the contraindications for open surgery would be inadequate conservative management. Now, early intervention can be good in patients, particularly with an anchored disc phenomenon where the two joint surfaces are fusing together, as described by Dorrit Nitzan and Frank Dolwig. An asymptomatic contralateral joint, there seems to be a trend towards saying, oh, well, if we're operating on one joint, we should operate on the other joint as well. I don't think there are any orthopedic surgeons out there that would say if we're doing a left knee arthroscopy, we always should do a right knee arthroscopy. So I don't agree with that principle. No response to local anesthetic in the joint. Why would we expect a result with surgery? Arthroscopy or arthrocentesis were not attempted for reasonable reasons, or less aggressive modalities may be possible. Or the patient needs to go direct to joint replacement, such as patients with ankylosis, joint collapse due to inflammatory or idiopathic resorption, or in severe cases of degenerative disease, Wilks stage 5. My concern with the Dimitroulis classification, which Darpan mentioned earlier, is that it's about treating the scans and the findings and not treating the patient. So I'm not alone in not using the Dimitroulis classification, as I have concerns that it's based on treating scans. And I've seen a number of patients where the scans look dreadful, but the patient has a mobile joint with no pain. So treat the patient, not the scan. And certainly I would not treat a patient with painless anterior disc displacement. Otherwise, we'd be treating 30% of the population. So we have a number of surgical alternatives: eminoplasty or adjustment of the articular eminence, discectomy, displication, condylar shave, eminence augmentation, down fracture of the eminence or modifications of the Dautrey procedure, coronodectomy, and condylotomy. And I'll deal with some of those in the next 10 minutes. So for recurrent dislocation, we should consider less aggressive options first, and we've already mentioned autologous blood injections. These are successful in controlling recurrent dislocation in a number of cases. The potential problem with that is that it can induce fibrosis within the joint, and the addition of IMF to that will immobilize the joint, which is likely to induce fibrosis more positively. However, that is probably what you're wanting to achieve because you want to reduce the mobility of the joint. So it's a fine balance. Prolotherapy, I've been using 20% dextrose for the last 6 or 7 years, and I find that around about 60 to 70% of my patients get better with an injection of 1.5 ml of 20% dextrose into the retrodiscal tissue and 0.5 ml into the lateral capsule. It is, despite good local anesthetic, a painful procedure, and the patients often complain of pain within a minute or so of the injection due to probably a hyperosmolar response. Botox to the lateral pterygoid has also been used and is considered to be responsible for reducing the pull on the articular disc due to the attachment of the lateral pterygoid to the front of this. Sclerosants have been mentioned, but largely we've abandoned those these days. So the surgical alternatives for recurrent dislocation would be scarification of the retrodiscal tissues arthroscopically, or similarly you can carry out arthroscopic eminence reduction using some form of grinding tool. You can reduce the eminence in an open method. You can augment or build up the eminence, as you see in the picture on the bottom left, or you can down fracture the arch, Dautrey type procedure on the bottom right picture. When you now start moving on to open joint surgery for internal derangement, there are a lot of common misconceptions in this. And we have to say that if you have a hammer, everything is a nail. So if you have one surgical technique, you try to adapt it to everything that you're doing. But what you should be doing is basing the management on your surgical findings and not on what you like doing. So you need to have a full surgical armamentarium of internal articular procedures. When you look at the literature prior to arthroscopy, all options, discectomy, condylar shave, eminence reduction, give an 80% chance of the patients getting about 80% better. But this isn't the case after failed arthroscopy, as was shown by my early studies and also by studies from Holland, when arthroscopy gives us, following arthroscopy, the success of open surgery is closer to 60%. And when the air hits the joint, it's never the same again. You have to warn the patients that there's an increased risk of degenerative change when you open a joint, and therefore of joint replacement. So you shouldn't be doing open joint surgery lightly. You should consider all other options prior to this from a primum non nocere point of view. So looking at eminectomy, there's a lot in the literature that says it's an extracapsular procedure. I fail to understand how an extracapsular eminence can be approached through an intra-articular arthroscopy. So I don't believe the eminence is extracapsular. It is, however, a relatively easy procedure to perform, but as you look at this picture on the right, the middle cranial fossa can be in jeopardy if you angulate your tools too far superiorly. So be very careful with that. Gerhard Hunt very cleverly showed that removal of just the lateral third of the eminence is sufficient to reduce the recurrent dislocation rate, and you don't really need to do the deep excision for hypermobility, which has frequently been suggested. And also there's a number of studies now which suggest that around about 5% of the population have mastoid air cells which extend into the articular eminence, and therefore there is a risk of damage and exposure of the joint to the infected mastoid cells, and therefore a risk of infective arthritis following that procedure. So it may be worthwhile considering a CBCT scan prior to carrying out an eminectomy. High condylar shave, removal of the proximal 2 to 5 millimeters of the condylar head, is used regularly in the management of condylar hyperplasia as one alternative to stop growth. The other alternative is to carry out a much more radical condylectomy, which is a proportional condylectomy to try and level the length of the ramus on both sides and allow adaptation, which may prevent subsequent orthognathic surgery. Can also be used to deal with the osteophytes of osteoarthrosis or the erosions that you can see in degenerative disease. And it has been suggested as a method of joint decompression to allow more room for the joint to move in. Displication is said to be useful for dealing with hypermobility. It can reposition the disc into a more normal anatomical position, and it can reverse the hypomobility where a disc is stuck anterior to the joint itself. It is repeatable, so that seems to suggest that when you've done it once, that the cause that's causing the stretched retrodiscal tissue is still there, which is clenching and grinding. And so it isn't addressing the pathological cause. It relieves pain because you're removing an area of thickened retrodiscal tissue and synovitic tissue, which is sensitive, and therefore the disc, which is avascular and doesn't have any nerve supply, can't feel the pain. It's difficult to perform this very well, and therefore it's even more difficult to perform this arthroscopically very well. And when you look at the long-term reviews of this carried out in the 70s, 80s, and 90s, a lot of patients are coming back to have the procedure repeated. And ultimately, once they have 2 or 3 repeats, they end up needing an alloplastic replacement because there's degenerative changes that's occurred. Discectomy is said to be an easy to perform procedure. It isn't an easy to perform procedure. It's very difficult, often down a deep dark hole, to gain control of the bleeding on the medial and anterior surfaces where the pterygoid is attached. It's also essential to remove the whole disc, otherwise small fragments will cause sticking, catching, and pain. Discectomy itself gives good pain relief, and it, not surprisingly, eliminates the click. However, subsequently, if you take an X-ray, it will show remodeling of the joint surfaces. And if you base your treatment subsequently on the MRI, CT, or plain radiographs, rather than on the patient's symptoms, you will end up replacing the joint. Should you use an interposition at the same time is another debate, which Florencio kindly asked me to address in one of the journals that he's leading an article on. And what my findings was that if you're going to use something, the best thing is either free fat or dermis. What they do is give good initial pain relief. However, in the long term, with no interposition, you get better opening and the pain is equivalent after 6 months. So what you're gaining with initially is some pain relief. What you're losing is also not only long-term results not as good, but also you get second donor site potential complications. And there's a risk of calcification of the interposition, which can lead to ongoing problems. When you don't do an interposition, you mobilize the patient post-operatively, they get a fibrous neodisc, and therefore this acts as a new disc with a remodeled joint surface to accommodate that. And what we need to consider is, what do our orthopedic colleagues do? Because let's face it, they do a lot more joint surgery than we do. And what they do is address the pathology, they preserve normal anatomy, and they repair or replace abnormal anatomy. And based on that, I would like to propose a pathological basis to manage temporomandibular joint internal derangement. So preserving normal anatomy, we don't always do a eminectomy. I've seen a number of patients who've had an eminectomy carried out elsewhere and have come to me for further management, who, when you open the joint up, have a disc tear. Was that there before they did the eminectomy, or was that created by the procedure of the eminectomy? We don't know. Don't operate on asymptomatic joints. The same would apply with arthroscopy, and don't treat a click alone. 30% of the population have a click, and therefore we'd be treating a lot of patients. To quote Gandhi, freedom is not worth having if it does not include the freedom to make mistakes. But what we need to do, as Florencio has always also stated, is we need to learn from our mistakes. Because Einstein would say insanity is doing the same thing over and over again and expecting different results. So why repeat a displication when it hasn't worked the first time? So this pathological basis to manage TMD. So address the pathology, reduce the eminence if it's degenerate, if it's enlarged, or if there's lateral lipping, which can cause impingement. If there's adhesions in the upper and lower joint space, we should free those. If the disc is stretched, has stretched retrodiscal tissues, we can reduce those and similarly get rid of a thickened area of sensitive retrodiscal tissue. If there is a disc tear and it can be moved off the articulating surface, then we should try to reposition the disc into that position and allow maintenance of that part of normal anatomy which remains. If not, a full discectomy should be carried out. There is no role for partial discectomy in TMD. And finally, a condylar shave if there is evidence of osteophytes or erosions, to provide a smoother surface to allow remodeling to occur. So repairing or replacing abnormal anatomy, disc repair if there's a small posterior or lateral tear, reposition an abnormally displaced disc, or joint replacement if there's marked joint damage from condylar collapse, ankylosis, or severe degeneration. And this is just an example of a type 3 type of ankylosis, where you can see from the CT scan there's considerable fusion of the lateral portion of the condyle to the zygomatic arch, but relative preservation of the medial structures. And there's a number of studies, and the one from below is one that I've just used as a highlight for this, which carries a large number of patients and was published from India. So this is a young girl who fell on her chin 4 years previously. She's now 12. We open up the joint. I use a piezo as per Ajoy Rod Chowdhury's guidance to remove the bone, as this gives less bone debris and less burning of the bone. You then remove a wedge of bone and expose the medial tissues, which you can see down at the bottom on the side. Pull the medial tissues over the new joint surface. And what I use is what I call a Yorkshireman discopexy. I'm a Yorkshireman, we're meant to be tight with our money. And when a mitre anchor costs about £500 and one screw costs about £80, I think I like to save a little bit of money. So we put 2 screws in the condylar head, and I'll show you the technique shortly, but use it to hold the disc over the condylar head. So this is the Yorkshireman discopexy, which was published 2 years ago now. A screw in the posterior condylar head about 5 millimeters from the proximal end of the condyle, one in the lateral pole. These can be resorbable screws or standard 1.7 millimeter screws. We then place PDS in a double root posteriorly and loop it round the screw, and then again laterally to pull the disc posteriorly and laterally to reseat over the condylar head. And this is the result at 1 year down the line. So you can see she gets good mouth opening, a little bit of deviation towards the side. You can see the scar on her chin from the fall. She is now 6 years post-op, no problems, no pain, mouth opening maintained at 44 millimeters. So preserve as much as you can of anatomy. And yes, the X-ray looks completely abnormal in the condylar head, but I'm not planning to replace that joint just because the X-ray doesn't look right. We then need to work out how we measure our success. So how do we measure outcomes? And we need reproducible, objective outcome measures. And all of my patients, I record at every visit their mouth opening, a VAS pain score either from 1 to 10 or on a 10 centimeter analog, and then dietary scores from 0 liquid to 10 solid, so that we can monitor outcomes and we can see where a patient is progressing, because they may come back and say, oh, I'm no better, doctor. And yet when you take their pain score, it's moved from 8 to 5. And so you can see whether what you're doing is moving in the right direction. And we similarly need reproducible subjective outcome measures, quality of life measures, PROMs, etc. And what is acceptable function? What's an acceptable pain score? What is success? What's acceptable mouth opening? And in my mind, a pain score of 2 or less out of 10 and a mouth opening of more than 30 millimeters is a good outcome, which I cannot improve with any further surgical intervention. Never, ever tell a patient you will cure them or completely relieve them of pain. What you're trying to do is manage their condition and facilitate them to heal themselves. The one thing that I would say to everyone is, based on the joke, that what is the difference between a surgeon and God? God doesn't think he's a surgeon. But as a surgeon, we've got to accept that it's God who is healing our patients and not ourselves. And what we're treating is our patients. We're not treating ourselves. We're not treating our managers or our purchasers. What we want is a better quality of life for our patients, which is manageable with relatively little pain and good function. So this is a study I alluded to earlier, which was Anders Holmlund, who is probably one of the leading experts in the world at looking at outcomes from discectomy. And when he looked at discectomy following arthroscopy, he found that only about 55% of the patients in this group improved, as opposed to 86% in a group which didn't have prior arthroscopy. So a number of patients will benefit from arthroscopy and don't need to go up directly onto open surgery. And we had the same with this perforation of the disc that I showed earlier. Wait, see if they get better with the arthroscopy. This was my early series of patients, and I was disappointed with this until the study from Holmlund came out as well, that I was only getting about a 60% success rate following failed arthroscopy. Then moving on in a series of patients when I'm doing a lot more open surgery because I'm getting a lot more national complex referrals. 79 patients, again, majority female, in a 3-year period with up to 1 year follow-up. And they are all now at 1 year follow-up, but I haven't got the publication through yet. So what you see with this group of patients is that pain recovery is slow. These patients are having the pathological based management. So they're having a discectomy if the disc is irreparably damaged, the eminence smoothing if it needs, the condyle smoothing if it needs, all 3 if necessary. And the pain recovery following surgery to bone and following removal of disc is slow. So you need to be patient. You don't jump in and do anything too soon. However, recovery of opening is much quicker. And what we need to do is get the joint functioning. That means mobilize the patient, physiotherapy from day one, active movement, get the patient to open as wide as they can, hold it 7 seconds, relax. 7 repeats every couple of hours the patient's awake. And that way you're getting a patient moving and you're getting a joint healing, because you want the joint surfaces to remodel, adapt to the new position. And at 1 year, 37 of those patients at that stage, but this is reproduced with all of my patients. I've got now about 120 in this cohort. The majority have an opening of greater than 30 millimeters. Resolution of symptoms in 24 out of 37, with improvement in symptoms of 5. That means a pain score of 2 or less out of 10. 8 went on to joint replacement. So I count those as a failure. However, you'll see from subsequent slides that joint replacement is an outstanding management for this. So the success rate of 78% is coming close to that 80% magic figure that we used to see with any form of open joint surgery. And that's after failed previous arthroscopy. So I define success with a patient who is discharged and happy with their outcome and can manage their life. And we would say that all the 8 joint replacements are probably successful also. Again, back to what to do when it fails. And when it fails, you treat what you've found. So if you found a pretty badly damaged joint and they haven't got better, you're realistically saying, okay, we need to do an alloplastic replacement. And you will have warned the patient that that's a possibility before you've started and told them that there's a 20% risk that they may end up with that. If there's nothing, if you found a normal joint, then do not be tempted to go back into that joint again. Send the patient for pain management. When it fails, so predictors of success of open surgery. So what we found in this early study was that Wilks stage 4 and 5, a lot of those patients ultimately went on to do joint replacement. That's much less now, and I would say I'm probably closer to about 40% go on to joint replacement with Wilks stage 4 and 5. A high initial pain score is a bad predictor of good success. So a greater number of patients will go on to joint replacement who have a higher initial pain score, and a greater number of patients with limited mouth opening below 3 centimeters will go on to need joint replacement. So this was an early series where 39% went on to joint replacement, whereas you can see from the previous series, it's closer to about 20%. So what to do when it fails? Wilks 4 and 5. Should we be going straight to joint replacement? Well, no, I don't think we should, because increasingly around about 50% of my patients with Wilks 4 and 5 get better with either arthroscopy or open surgery to deal with the problems. And one patient I vividly remember is a lady that I treated in her 60s, who, when I opened the joint, it looked as though someone had taken a golf club to her condylar head. There was a big scoop out of it. Her disc had a massive hole in it. The eminence was irregular. I smoothed the eminence, I took the disc out, I smoothed the condylar head, and I went to her in the post-op room. I said, look, I'm very sorry. The joint was a mess. I don't think this is going to get better, but let's wait and see. 6 weeks later, she came back pain-free with an opening of 36 millimeters. Don't despair when you open a joint and find it's a mess. Do what you can, do as much as you can, but as little as is needed. Don't do things that aren't needed, and you will be surprised by the success you get. The procedure that you would do is dependent on what you find, and using that technique, you might end up doing a lot more than one procedure on the same patient. So where are we now? And I think we're still in this dark age of saying, oh, well, I would always do this, I would always do that. No, we need to be referring patients to clinicians who have expertise in doing this and who are doing it frequently and not having a go. And therefore, we need to look at units with specialist abilities, with 2 or 3 surgeons in that unit who are taking referrals from around the area and focusing their care on those cases, because that's what orthopedic surgeons do. We now have foot and ankle surgeons, knee surgeons, hip surgeons, shoulder surgeons, elbow surgeons, hand surgeons. Why don't we have maxillofacial TMJ surgeons? And I think increasingly we're developing these, and we should be doing so, and it should be encouraged by all our other colleagues. So this is the kind of pathway that I would like you all to consider following. A period of conservative management, albeit shortened if the patient has an acute severe restriction of opening, which suggests an anchored disc phenomenon. Moving on to arthroscopy, which is both the best diagnostic tool and also gives a good therapeutic success rate of around 80%. Followed by open surgery when indicated, using a pathologically based approach, which gives a success rate of around 80% when using that technique. And then moving on in those cases where the joint is badly damaged and fails to improve, to joint replacement. And when you do joint replacement, this is a study that we've just published looking at patients at 10 years following alloplastic replacement using the TMJ concept system. And Lou McCurry's study at 20 years shows that these prostheses last even longer. TMJ replacement is an end stage operation, so do not undertake it lightly. Do not just have a go. It needs to be done by someone with experience. And when you have that surgery done by someone with experience, the outcomes at 1 year are pain scores of less than 1 out of 10, dietary scores of 9+ out of 10, and a mouth opening average of 33 millimeters. That was my 1 year study. At 10 years, those outcomes are maintained. And the publication is in the International Journal of Oral and Maxillofacial Surgery. There are failures, and the failure rate of alloplastic replacement across the board, most people get similar sorts of outcomes. 2% rate of infection, which means the prosthesis needs to be removed. 2% of ankylosis cases re-ankylose. And I've done around about 90 ankylosis cases now, and we've had 5 re-ankylosis in those. So it's a little bit higher when you look at that small group, but of those 5, all of them I've managed by taking the prosthesis out, resecting the recurrent ankylosis, and putting the prosthesis back in at the same sitting. And I've now got 3 patients at 5 or more years where I've done that haven't had a re-ankylosis. Thank you for your time. I'm more than happy to take questions, and I know that Taranjit has set up a question group so that you can ask questions after this event, and we will get back to you with that.
Thank you so much, Dr. Sidebottom. This has cleared, I'm sure this has cleared the algorithm, the treatment algorithm for the open joint surgeries has been so concise and precise for all of us. I'm sure that a lot of us who, through our knowledge and understanding, blurred knowledge and understanding, which we gain on the go while doing these patients. I'm sure with this particular lecture, a lot of our doubts are cleared and we'll be able to do much better for our patients. And with this, I open the forum for the panel discussion, which will be taken over by my dearest friend, Dr. Nehal Patel from India, Surat. And he actually, in Indian audience, hardly needs any introduction. Dr. Patel has been extremely well-known personality in the field of arthroscopy, in fact, a pioneer in his own way. And he's the right person to handle this panel discussion for me. Dr. Patel, the floor is all yours. Thank you.
Thank you, Dr. Taranjit.
And I'm sorry for the delay of the session. Let's try again.
Yeah. Thank you, Dr. Taranjit. I think it was an excellent session, and most of the questions which come across our day-to-day practice has been covered by Darpan, Dr. Monji, and Dr. Sidebottom. So I think I'll just summarize the entire this session by giving a conclusion. So when we see a TMJ patient, it is important to understand the etiology. Most of the patient, when they get treated with the conservative, early intervention of the acute cases, as Professor Monge and Sidebottom also said, is upward important, and repeated conservative treatment for a long-term conservative treatment can lead to a problem. So this is what we have to understand. I'll ask, I think my questions are, most of the questions are answered by Andrew, because he has covered it nicely, and a few of them are answered by Professor Monge. I would like to ask Professor Monge only one question. Sir, say if there is a failed lysis and lavage, and when you do a level 1 arthroscopy, what is your indication to do a suture arthroscopic suture discopexy? I mean, is there any criteria you follow while doing a suture discopexy for the patient who has failed level 1 arthroscopy or lysis or lavage?
Okay. It's a nice question. The question, I repeat the question, if it's, what is the criteria in relation with these repositioning techniques in arthroscopic surgery in comparison with the lysis and lavage?
Yes.
The criteria after 15 years of protocol is that the lysis and lavage is the most universal technique used from stage 2 to the stage 5 of Wilkes. But if you have training, if you have enough space in the upper compartment, and if you have a stage 2 or 3, you can try restructuring technique. As is very clear. In cases, if you, the most important, if you have no experience, please do not practice the suturing techniques. But if the patient is with advanced stage 4 or 5 of Wilkes, please do not resuturing techniques in our hands.
Okay. Thank you, Professor Monge. Darpan, I have one question for you. See, in your practice, where do you put a stop for the conservative treatment? I mean, is there any time period, say if there is an acute case where a young patient with the acute case between the age of say 15 to 20 years, and is there any time frame where you put a stop for the conservative treatment? Say this is the time frame I would try to do a conservative treatment, and then I'll put a minimum go and do arthroscopy or arthrosynthesis.
Thank you, Dr. Neil, for that question. Actually, it is more on a case-based scenario. For example, if we take a case of a disc displacement with reduction where the patient comes with a symptom, say patient presents with pain. Now we go ahead with conservative modalities of management, and beyond 3 months, I think, is the time where we should not wait in a case with disc displacement with reduction. But when it comes to a scenario on case where you have disc displacement without reduction, I think beyond 4 to 6 weeks, you should not extend your conservative modalities, because that's the time where a lot of fibrosis will set in around the non-reducing disc, which makes things much worse to handle than doing an early, even simplest of intervention.
Okay. Thank you, Dr. Darpan. I have a generalized question for all three of you, Andrew, Professor Monge. Say very young patient between the age of 11 to 20 years, when they do come with the anterior disc, symptomatic anterior disc displacement without reduction, would you do a more aggressive procedure like open joint surgery or aminectomy in those patients, or after say failed arthroscopy, when they come after arthroscopy has failed, would you recommend to do open joint surgery? Andrew, can you answer the question, please?
I can hear the question, please. Yes.
So the question is, say the very young patient between the age of 11 to 18, when they come with the symptomatic anterior disc displacement, and when we do a lysis and lavage, and then when they come back with the pain again, this fail arthroscopy, would you recommend doing an open joint surgery on those age group patients?
Okay, probably the question is addressed to re-arthroscopy. If I have a young patients, if we fail with a lysis lavage, we try for a second arthroscopy, no more than 2 arthroscopy. Many years ago, we practiced a gincana of arthrocentesis, 3 arthroscopies, discopexy, other discopexy, discectomy. Now, after years of office, I have to tell you that only 2 arthroscopy. Only 2 indications for 1 arthroscopy. If after the first arthroscopy, the patient is with the same symptomatology, in the MRI, you can see severe degenerative changes, no sense to make once again arthroscopy. And the second indication for 1 arthroscopy, if you, after the first arthroscopy, the patient feels worse, no improvement, but you see in the MRI, in the post-op MRI, a decrease in the volume of the upper space, no sense to other arthroscopy. In this case, probably the best way to go is discectomy.
Thank you, Professor Monje. Andrew, can you just elaborate on the importance of the physical therapy post-arthroscopy? Yeah,
sure. I agree with what Florencio said. The only other aspect I would add is that if you go into a joint, particularly in a younger patient, and it's bright red, it's very suggestive of inflammatory arthritis. And those patients have, by and large, need medical management with immune modulation drugs. And then potentially, if the disc is dissolved, they will go on to a discectomy. Physiotherapy is the key to recovery of any joint. Movement is the key. If you can get a joint moving, the muscles start allowing the joint to readapt, remodel, remold, and pain starts to reduce because it's moving away the inflammatory mediators and getting things going. So I mobilize all of my patients from day one. I use a standard 7-7-7 technique, which is active movements, get the patient themselves to open their mouth as wide as they can, hold it for 7 seconds, relax, repeat 7 times, and then do that 7 times a day or every 2 hours that they're awake. And then after a few days, I would then start getting them to either use something like a therabite device, or if you haven't got that, spatulas or just finger and thumb like that to open things up. And it's just that passive movement that gives a little bit of extra stretch. And it's a huge, I think it's a huge thing to get the patient moving, no matter what you've done, whether you've done a dislocation or not. If you've done a dislocation, are you worried that your sutures are going to pull out? Well, if you are, then you haven't put your sutures in properly. So you need to mobilize a joint because you've got to get the blood clot out of the joint that stops, that causes fibrosis, and you've got to get things moving.
I have a question, Andrew and Florencio. How important is we talk about diagnostic arthroscopy and then there is an MRI. So, how do you sequence this? Now, anyway, you're entering the joint and you're going to see everything through an arthroscope. So should we be taking, because, getting the MRIs is adding a cost to the whole. So when we are doing something in the form of diagnostic, then MRI or by MRI?
Okay, can I answer that first? Because Florencio will give a completely different answer.
Okay.
I very rarely do any MRIs.
Wow. Okay.
I use
that is
my
so
fingers.
heartening because it's so difficult.
I use my ears and I use my fingers.
Okay.
And so I listen to the history and I palpate the muscles and I palpate the joint. And then my diagnostic aid is my arthroscopy if I feel I need it. There you go.
Wow.
Florencio,
Yeah.
I agree with you. Sensitivity and specificity of clinical exploration against MRI probably is no difference in hands of the veterans, in hands of the experts, in hands of the clinical. But, you know, in Europe, in Spain, you need MRI for legal considerations. Israel, quite difficult. It's more. Probably you trust more on your arthroscopic findings intraoperatively than in the MRI findings.
Wow.
And I think the other comment, Taranjit, is do not base your treatment on the MRI. Base it on what you think.
Yes, that is what you say. That is what Nitzan says. That is what I think Dr. Mercury also says. Dr. Mercury, I don't know. I can see his slide, but if he's around.
Okay.
So I think that is what experienced people like your kind self have seen, and even so. The reason why I asked you this question is we don't have in government facilities, we don't get MRIs, and then we are worried whether we are doing harm to the patient because we have not ordered an MRI. And I'm sure there are a lot of people coming from places, and even if you order, our radiologists are not aware of how to take it, what slices to, and they ask us for interpretation. So that's a very difficult spot to be in. So this particular thing has been there in my mind since forever. And the other thing what I wanted to ask Florencio particularly is the placebo effect, because I have seen a documentary where, the in the knee joints, particularly the chronic knee pain, they did an arthroscopy just, as a placebo for the patient to know that some intervention is done, and they recovered. So how much what is your experience with placebos? You might just, you might just
you're completely right. First of all, probably some of us have an inferiority complex in relation with other specialties. Yes. Because you are completely right, Taranjit. In the orthopedics, the arthroscopy is very discussed, is very controversial, because in some meniscal tear, 6 months after the arthroscopy, probably best result for arthroscopy, but 12 months after the arthroscopy or no arthroscopy is the same results first and the second. Yes. Placebo effect is the same placebo effect in some patients in the knee surgery than in the temporomandibular joint surgery. What is the percentage of placebo effect? Depends on the patient, and depends on your comments to the patients, But it's possible to support the to wash out the inflammatory mediators, mobilization, denervation, metaplasia, but 1%, 10%, 20% of placebo effect. You have to say to the patient, your temporomandibular joint is completely wrong, but you don't worry. I do everything to feel very good inside of your joint.
I got that. Thank you so much for this. Dr. Dale, do we have any more questions, or should we allow our esteemed guests to take some rest from us?
Yeah, I think we should wrap up this session.
So I would like to thank all my guests and attendees today evening. Thank you so much, Andrew, Florencio, and Darpan, for coming today. Namaste to all of you, and and all the attendees who have come and given their time. And I hope that they're leaving this session with insightful thoughts, and I'm sure they will serve better their patients. Yeah. Thank you so much. Yes.
Thank you. Great experience.
And I'm sure this education will continue. We will continue to get educated.
Okay. Nice weekend. Yeah. See you, Andrew, on the Wednesday or Thursday.
See you Wednesday. Yeah.
See you.